I'm going to talk in the next 13 minutes or so on the issue whether troponin rise is a reliable indicator of myocardial necrosis. I will do that in several parts. First, let's focus on the surrogate value of a troponin rise for identification of necrosis and not reversible injury. So when we look at the cardiomyocyte, you see the organized structure of the sarcomere. After 40 minutes of ischemia, there is mitochondrial swelling, but no change yet in the sarcomeric structure. When you look at 24 hours after coronary artery occlusion, still there is no morphological change in the contractile machinery. And when you look at 7 days after myocardial infarction, you still find fragmented sarcomeric proteins in the infarct zone. Now, when you now look at the serum concentration changes of troponin T, in this case of a patient group with non-reperfused myocardial infarction as compared to reperfused myocardial infarction, and you consider that the half-life of troponin T is 90 minutes in circulation, so the persistent elevation then of troponin beyond day 2 means consistent and ongoing degradation of the contractile machinery, and that, I believe, is a hallmark of irreversible myocardial necrosis. Now, what about the release of the functionally unbound cytosolic pool, which is washed out followed by due to reperfusion in patients with reperfused myocardial infarction? So there are no clear data so far whether it is really possible to have a release of troponins from reversibly injured cardiomyocytes. Here you see an in vitro cell system of cardiomyocytes exposed to hypoxia. And what happens is there's a plaque formation on the cellular membrane, and with that plaque formation, there is an egress of cytosolic markers into the tissue culture fluid, and you can measure elevated CK and MB activities. And when you then reoxygenate the tissue culture system, the myocardiomyocytes look functionally intact and are also viable for a prolonged time period. Do we have in our patients evidence that there might be early bumps of troponin without the ongoing degradation of contractile machinery? I show you here data from pulmonary embolism patients, but we could show also data from patients with atrial tachycardias, where you might find some patients with an only initial rise of a troponin, and I am not certain whether that is not indeed some form of reversible injury. So this brings me to the second point, namely the highly sensitive assay for the myocardial infarction diagnosis. Do we have added value? Now, there's ample evidence for many, many trials, and I show here data from Alan Shafi's group, that with any release and any detectable troponin in circulation, you have a prognostic signal. So the more troponin release, the more the worse the outcome, and any release is associated with a higher risk, both for survival and for readmission for heart failure and myocardial infarction. When we used our high-sensitive troponin T assay, which allows the measurement at the 99th percentile with 10% coefficient of variation, so with the required analytical characteristics, and we have 3 negative measurements in patients in our chest pain unit, these patients have an excellent outcome, whereas those who have an elevated troponin have a worse outcome and high cardiac event rate. Now, this brings me to the third point then. Do we need to analyze kinetic changes? And to show you what the problem is, and it was already alluded in the discussion, when we use such high-sensitive assays, we detect myocardial injury of many causes and in many patients, and we know it's always associated with outcome. So when we tested our consecutive patient in our chest pain unit, 3,327 consecutive patients, which were measured within 6 months and visited in the last 6 months in our hospital, you can see that 20% of the consecutive patients admitted are positive for a high sensitive troponin T. However, 69 of these elevations were rated not to be related to an acute coronary syndrome. So we really have the problem now that we detect these myocardial injuries, but we do not believe that it is always associated with an ischemic damage. So therefore, let's look back to the criteria. The criteria for myocardial infarction as defined are that we have to have evidence of myocardial necrosis, and I showed you that the persistent elevation of troponin is, in my opinion, a clear evidence of irreversible necrosis, together with evidence of myocardial ischemia, and then we have to have a kinetic change to differentiate it from the elevations of troponins due to other causes. Now, when one does analyze these kinetic changes, you can do it as an absolute delta, so that means you measure on admission, and at 6 hours later, and you then find that in the STEMI group, you have an increase of 674 nanograms per liter for the high sensitive troponin T, and for the in the N-STEMI group of nearly 60 nanograms per liter, and in unstable angina you do have no change. Now you also can express that as a relative change, then you are not so much dependent on infarct sizes as with the absolute deltas. And again, you can see that in non-STEMI, you have in the median of 62% change in the concentrations from admission to 6 hours later. You can do ROC analysis and identify the optimal cut points for differentiation and diagnostic classifications. And the best performer was the maximal absolute difference from 0 to 6 hours after admission, which was 9.2 nanograms per liter as a discriminator value, absolute, or if you want to use the maximal rise, and that is also only for the N-STEMI group, since in the STEMI group we won't need such an analysis, it's 40% increase, which gives you a good separation of the STEMI versus non-STEMI. However, there is also in those other conditions some change, some kinetic changes of the troponins. Those who have troponin elevations due to other cardiac diseases like heart failure, vascular disorders like stroke, systemic disorders like sepsis, non-cardiac chest pain, and so on. And so you can see that you have a change here in the range of 5 nanograms per liter, also significantly less. Now, there were many investigations, and we had also some data, and these are data again from Alan Chaffee's group. Can we use these delta changes to give some indication on outcome? And the answer is most probably only for the large infarcts, since for the smaller infarcts, the predictive power of the delta changes, both relative and absolute, are only insignificant. So this brings me then back to the last point, and I would like to show 2 clinical examples before I summarize the data, just to illustrate the problems we are facing when we apply these high-sensitive troponin measurements. So this is a 48-year-old male without any cardiac risk factors. And he came to our chest pain unit with chest pain, hypertensive blood pressure, and moderate tachycardia. And you can see that there was some ST segment depression, and he had a clear kinetic of the high-sensitive troponin T assay. So per definition, with chest pain and troponin kinetics, this patient would rule in for myocardial infarction, and the ECG is in accordance with an N-STEMI. Now, when we look at this coronary angiography, you can see a high-grade proximal LAD lesion, also in the LAO projection. I'm stuck. Can you move that next? Okay, when we look at the ventricular angiography, you see that there's some slight hypokinesia at the anterolateral wall and the septum. Now, the point why I'm showing you this case is when we send, you need to move it, thank you. When we then looked at the MRI for late gadolinium enhancement to really prove that he had indeed myocardial infarction, we were not able to find any late gadolinium enhancement. So this gives you one of the issues we have when we measure such sensitive with such sensitive methods that there is no gold standard, no imaging methodology which gives you comparative analysis and provides you sufficient sensitivity to assess the troponin measurements. This is a second example of a 60-year-old female with unspecific pain, hypertension, but no changes whatsoever in her ECG, but marked changes of troponin. Now again, it's a difficult case, and when we look at the angiography, you can see that it's excellent ventricular function, eventually some reduction in contractile strength as the inferior wall or inferior apical part of the heart. When we look at the coronary angiography, I need your help again, then you see essentially normal coronary arteries. So what is the diagnosis now in this female lady? And since you would say, well, that's again a false troponin measurement. So in this patient, then we did again our MRI study, and you can see that there's clear evidence of late gadolinium enhancement on two different spots. So eventually this patient had coronary artery spasm or thromboemboli, which we were not able to pick up. So this brings me to my conclusions. First, troponin elevations on day 3 to 4 post-symptom onset reflect degradation of the sarcomere, which is a hallmark of myocardial necrosis. High-sensitive assays identify more patients with myocardial infarction. It's about 30% more patients with the high-sensitive assays as the conventional troponin assays, and they facilitate risk stratification with an excellent negative predictive value. You have many more patients which are troponin positive, but these patients also, when they have not ischemic injuries, have a high cardiac event rate. Analysis of troponin changes, either absolute or relative, improve precision of AMR diagnosis. However, we need more data on the exact optimal cut points to be used. And finally, and that is a key problem we face now with this very sensitive assay. We have there is a lack of diagnostic methods to validate a positive troponin result in the patients with suspected acute coronary syndrome. But as indicated, it is no way back, and there is a clear advantage when you identify a troponin in your patient with a suspected ACS, since you can start your treatment. And thank you very much.